All right, I'm going to take a break from GI and all the other stuff, and I'm going to jump into cardiac because we don't have a quick review for cardiac. So this is mostly going to be related to coronary artery disease. I know that that doesn't cover all of cardiac, but hey, I'm I'm throwing them through the line today. Again, this is the machine running. I think I've done 5 videos. I got one uploading, and I'm about to shoot this one through. So that's a lot for one day. So yeah, I hope you enjoy it, and I hope it's helpful for you for upcoming exams. So just as a quick introduction, coronary artery disease, or CAD, it's caused by plaque buildup in the wall, the arteries that supply blood to the heart, or the coronary arteries. It's very, very thick. It's like concrete. If you chip at concrete, that's what a cholesterol deposit is. It's not squishy like most people think. It's hard as a rock. The buildup causes the arteries to narrow over time because, again, this is a big, chippy kind of wall. Just a stone wall is kind of what it is. It's just very, very thin, and of course it topples over each other and creates layers. And over time it's known as atherosclerosis, which is, the narrowing of the arterioles. LDL, it's the biggest risk factor for cardio or coronary artery disease. And in this specific case, LDL is going to be your lethal and your HDL is going to be your healthy. And that's why I memorized it for myself because, I always have a hack for everything. And that was my hack 10 years ago when I started this whole thing. God, it's been 10 years. 10 years ago. And yeah, maybe it'll help you guys out. So I want you to know these levels because it's very important. LDL, you want to make sure that your LDL is under 100. That's the ideal. If you're at risk, you're going to be 100 to like 159. And then if you're above 160, you're in dangerous territory. When you're dealing with your total cholesterol, you want to make sure that you're under 200 is the ideal. That's the perfect world. You're at risk if you're like 2 to 239, and then if you're over 240, you're banging for problems. And then when you're HDL, you want to be above 60. If you are kind of considered at risk for having a lower HDL, you'd be like 41 to 59, and then below 40 is going to be your dangerous levels. So you want your LDL lower, you want your HDL higher, and we're going to get into what happens if you don't do it, what happens if you do it, what your dietary management and recommendations are going to look like, et cetera, et cetera. So types of coronary artery disease, there's three big ones. Obstructive coronary artery disease, non-obstructive coronary artery disease, not a lot of variants there, but still some. And then spontaneous coronary artery dissection, not my favorite thing in the world. And we will get into those piece by piece. So obstructive coronary artery disease, it means something's in the way, right? Something's in the way of your arteries, which is causing a disease process of obstruction. So it occurs when your arteries narrow due to that concrete that's just being layered and layered and layered on top of one another, which is called atherosclerosis. Atherosclerosis, there we go. It is the most common disease process related to obstructive coronary artery disease. And it's pretty well known within the entire nursing world and cardiac world that that's kind of your basic stage 1 issue. Now, as the artery worsens, it is basically just going to cut off blood flow to your heart, and that would be called a heart attack. That's a super bad day. And I know I told my AM people about the fireman hats. It is the ST elevation that shows you that you're having a STEMI versus an NSTEMI. Obviously, the STEMI is a big problem, and it requires immediate medical attention to minimize heart damage via an ECOS, depending on what's going on, or a stent placement, or a pacemaker, just a milieu of things, if you will. But the most common thing is to stent it out if you have the ability to do that. Usually they want to stent if it's 80% or above blockage, unless it's in a really, really gnarly place like the LAD, which is what they call the widowmaker. That's the left anterior descending. And the way I remembered it for me was the poor woman widow lost her lad. and LAD for LAD, and it's the Widowmaker, so there you go. That's all I had, and it makes sense, and it works, and I never forgot it, so maybe that'll help you guys out. All right, so unlike obstructive coronary artery disease where something's in the way, non-obstructive, pretty self-explanatory. There's nothing in the way, but there's other problems that are causing it. So compression or squeezing from the heart muscle, or they call them myocardial bridging, constrictions at inappropriate times, that's a vasospasm. Damages to the arterial lining, that's endothelial dysfunction. I'm not going to get like too tight into these, so don't freak out about it. We're going to go over it in the more broad spectrum when we go over these weekly lectures. So just hang tight with me, and I am going to consolidate those because I feel like there were quite a few slides as well. Not as many as last, by all means, not even close, but it was enough to where I'm like, yeah, we can shorten it down. There's some unnecessary things here. Malfunctions of smaller artery branches, what they call microvascular dysfunction. This is something that happens pretty common. Usually if you have something with the underbelly or the backside of the heart, which is called the circumflex, you'll have these issues. And then non-obstructive coronary artery disease, it can still cause many of the symptoms that you would see in traditional coronary artery disease. So you'll get your chest pain, your shortness of breath, those type of things. But people with non-obstructive coronary artery disease experiences angina, chest pain related to the coronary artery disease itself, while non-obstructive heart disease can develop in anyone, and unfortunately it's most common in females. So just to understand the difference between obstructive and non-obstructive, I think it's pretty self-explanatory at this point. If you have any problems with it, just let me know. I'm happy to help you out as usual. All right, so spontaneous coronary artery dissection. Again, not my favorite thing in the world. So spontaneous coronary artery dissection occurs when there's a tear in the coronary artery wall, partially or completely blocks the blood flow entirely. The tear happens suddenly. It presents as what feels like a heart attack. So you're going to have gnarly chest pain, especially on the left side or the center of your chest. It does not go away with the rest. And let me just go ahead and say this because you guys know way too much about me as it is, so we might as well just go ahead and throw it over the loop. If you guys ever look at my neck, you'll notice that I always have a necklace, and up under that necklace is a very, very large scar. And distal to that is a half sternotomy, right? Because when I was 27, I was told I was going to die in a year because of an artery dissection. So it was the aortic arch, which is kind of a big deal. There's two types of dissections that usually happen. It's either the aortic arch or it's the AAA, the abdominal aortic aneurysm, right? So mine was up top, and I had a thymoma, which is a thymus gland that turns into malignancy, and it was growing into that. So at 27, I had all of these symptoms. And the only way I can define it for myself is it feels like you stick a hot poker right through my heart, and then it exits out of the back of my spine in between my scapulas. And it hurt so bad I could not physically speak. I could not even open my mouth because my jaw hurt so bad. It was the craziest, most wicked, wild situation I've ever been through. And I have been through a lot of really crazy things in my lifetime. For sure, for sure. So please understand that this is a huge deal. It's an absolute emergency. Dude, I got helivaced out from Wright-Patterson Air Force Base and kicked over to Kettering. Big shout out to Dr. Cool, who is my cardiothoracic surgeon, who was fantastic. I couldn't have done it without him. Dr. Cool is his nickname, FYI. So, pain radiates from your chest all the way to your shoulders or arms. Yep, that totally was a thing. Sensation of fullness, pressure, squeezing on your chest. Yeah, I get that too. Shortness of breath even at rest. Yeah, you bet your sweet tail because you were in a sympathetic nervous system process. Also, I would include complete disorder and thoughts of doom and gloom because you really think to yourself, oh my, this is the end. This is what it's going to feel like. Okay, great. So that is spontaneous coronary artery dissection. I doubt you're going to forget it at that point because I gave you a vivid Picasso-related depiction of what that's like. So let's move on to the next slide. All right, so obviously coronary artery disease is a big problem, and obviously diet and lifestyle changes are going to be something that they want to do often. So we have a couple of diets to have a couple of, acronyms, if you will. In this case, it's, TLC, therapeutic lifestyle changes diet. So what they want you to really, really focus on is um, make sure that you are taking care of your mono unsaturated fats that are found in nuts, olive oil, canola oil. So 30% of those calories should go from those types of fats. They want you to make sure that you're switching your whole milk to 1% milk. They want you to make sure that if you drink, you only do a glass of wine for dinner for antioxidants or the equivalent of a beer, right? Because it's got barley and hops in it. Fish for lean protein versus red meats. And then the patient, this is always something that really bothers me is for whatever reason people don't think they can have peanut butter. Dude, you can have peanut butter with apples, bananas, sandwiches. Yes, I said sandwiches because you know what? You can go ahead and take the girl off the res, but you can't take the res out the girl. So there you go. So peanut butter sandwiches, you can absolutely have those as well. There's nothing keeping you from doing that. That's a common myth. Because people already think, oh, yeah, well, it's just nothing but oil. Well, guess what? It's the type of oil that we want. So no harm, no foul. So yeah, that is what that looks like. And I think we can go ahead and move on to the next slide. Okay, so when we're dealing with changes in diet, the worst thing you can do, especially in your first patient encounter, is to look at your patient and go, you shouldn't eat bad. You shouldn't smoke. Because they're going to go, oh, really? That's an incredibly revolutionary thought. Hey, guess what? I don't think I trust you, deuces. And then they will walk out of the room. So it's just a common thing. Nobody wants to be reprimanded. No one wants to go to get assistance for weight loss and hear, hey, you're too big. Well, no joke. Why do you think I'm here? Duh. No one wants to hear, hey, you eat bad. You have to stop it all. And by the way, you have this tragic coronary artery disease that is going to continue to debilitate you for the rest of your life until you just completely lose function altogether. So good luck with that. So this is the wrong way to treat these people. The right way to treat these people is to let them know that we're going to be successful if we take the patient's values into consideration. And what I mean by values is exercise preferences, food preferences. I mean, if someone has a food preference and it's like something with 2,000 calories in it, modify that recipe so that it includes all of the nutrients that you need and the healthy fats that you need to be able to make something that is at least doable, so that you're not saying you can't have that, period. Because the second you tell somebody you can't have it, the first thing they do is what? Want it. Which is why you never tell your daughters or sons when they're younger that they can't date a specific person. Because that will end up being your sister-in-law, mother-in-law, father-in-law, whatever-in-law, if you back somebody off, a friend, a relative, whatever, away from somebody else and say that, they're banned, they can't do it. That will be your biggest curse and your, ingrained karma that you put on yourself. So keep that in mind because patients are no different. They're people just like you and me, I swear, I promise. So the highest percent of the calories from fat that we need to let them know should come from, again, monounsaturated or polyunsaturated fats. It helps the patient modify, again, favorite high-fat recipes by using monounsaturated oils, which reduces the risk of these arterioles narrowing any more than they already have. It'll give the patient a greater chance for compliance with dietary recommendations that are super duper harsh. I mean, I don't know if you guys understand how this works because I know that you don't see the things that I see, not quite yet, but you'll have a person in there who's maybe 25 pounds overweight, and you will see a cardiologist wag a finger in their face and go, you can't have that salt, you can't have this sugar, you can't smoke, you can't do this, you can't do that, you can't even have nicotine. And I'm like, whoa, 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 whoa. You can tell a person that's been smoking since they were 14 years old because their dad probably gave them a pack of cigarettes and said, here you go, son, welcome to adulthood, because it was, I don't know, the 80s or 90s, because that's what all parents did. Well, not all. That's what a lot of parents did back then, which is super stupid. But again, it's the cultural narrative. It was completely normal, if you can picture that in your head, for, parents to smoke in the house. And when we see that as kids, we do it ourselves, right? So it is absolutely unrealistic to get in these people's faces and be ugly to them, especially when you're only like 25 pounds overweight. So this is a good solution to fix these problems and meet some middle ground and potentially, I don't know, make a patient happy and make them, I don't know, successful. Go figure that one. So make sure that you're working with them is all I can say about that. Now, low sodium and low cholesterol foods, they're appropriate, providing the patient with a list is not going to be successful in making dietary changes. So you handing someone a piece of paper and going, here's what you can eat and what you can't eat, that's going to work for about a day and a half because they're going to feel morally obligated if they even get to that point. And then they're going to get so angry with you that you're never going to see them again. So don't do that. If they're a smoker, do the 3-2-1 done method, which is what I do, and it's actually pretty successful. You look at your patient and their spouse, and you look at the spouse first and go, all right, you're not going to like what I have to say here. And then I look at the patient and go, but you are, because I'm going to tell you right now, you are smoking. And I'm not a big fan of that, but you know what? I'll let it ride for right now. So what I want you to do is on your pack of cigarettes, I want you to give 3 of them to your spouse and do that for 2 weeks. So you can continue to smoke as much as you smoke minus 3 cigarettes for 2 weeks. And then after that, you take 2 more out of the pack. So a total of 5. Hand them over to your spouse. Do that for 2 more weeks. And then do 6 for 2 more weeks, which would be 3-2-1, right? 3 and 2 is 5 plus 1 is 6. And then you do the done method after that, because when you're down to that many cigarettes, you jump off of it, use a nicotine supplement like a patch or an inhaler if you can, and then blow off of it completely. So this actually has a better chance of winning than anything else. This works incredibly well, believe it or not, with alcoholics. I love working with alcoholics and neuro. It's kind of like a thing that we do often. I've had so many alcoholics that were in such bad shape. They were seizing uncontrollably and had DTs. These guys have almost died several times. I even had a couple of famous musicians who were in the Dayton area doing a concert and had too much fun and then ended up in my ICU at Miami Valley. And, per the NDA, I can't really get into it. But I will tell you that they were some pretty famous people that I'm sure you guys would recognize. And telling them the 3-2-1 done method made them laugh and made them actually go, okay, I'll try it. And you know what? We're not going to stop these people from doing these things, right? What we can do is encourage them to try to make the next day better, right? Because in this world, that's all we can really do is just love somebody unconditionally, tell them that we're proud of them every day and we love them, and try to do the best that we can to educate them with the information that we know. Because we don't know everything, and we're not the best things in the world. We're not even close. But if we at least try to make somebody else's day better, then we've had a successful day in this world. And that's all you guys need to do, and keep in mind, because I know it gets frustrating sometimes, but you can't let it get to you. So make sure that you're trying to do everything that you can in the soul of your body and the core of your being to do these things and to find this common ground so that you can work together and be a little more cohesive in healthcare management. But again, it's not going to be a realistic expectation to just shut it all down in one day. So just get that out of your brain, and let's go to the next slide. All right, so when we're talking about exercise to improve the risk of coronary artery disease. We want to make sure that we're, again, continuing physical activities that people already enjoy. And we need to make sure that we're asking the patient about their preferred activities. I know that all these things sound super silly, right? Because you're in an acute care area, you have a patient who has coronary artery issues. They might have some other problems that are causing them to be in hypertensive crisis. You got huge things to worry about. The last thing that you're going to think about doing in this instance is go, hey, do you like to ski? Do you like to swim? Do you like to, what do you like to do? But this is going to be a conversation you're going to have when you got them all better. Not so much in the ICU, because you guys don't often discharge someone from the ICU, although it does happen. It's not very common, but it happens enough. It's like the perfect little snowflake, right? You rarely get to see it and look it up under a microscope, but when you do, you really respect it and you really appreciate it for what it is. So the goal is for us to achieve 30 minutes of moderate activity on most days. Now, notice I said most days, so the technical answer is 3 to 5. However, if you look in your slides, and we're going to go over them later on, your slides say 2 days. However, there's a difference, so don't let that confuse you if you do see it. The reason it says 2 days, because I had to read it again and look at it, is because you're dealing with someone who has significant coronary artery disease and or heart block or heart failure, which is going to basically render them unable to do any more than that in a week's time, because they got shortness of breath, they've got other concomitant issues that are causing them to have this type of trouble. So for the person who is at risk for coronary artery disease, we want to do 30 minutes of moderate activity on most days. We want the older adults, they should plan for a longer warm-up period so that they don't get gassed out. And the benefits of exercises, like improved activity intolerance, is a huge deal. It should be emphasized rather than aiming for, hey, you're going to lose weight. Because mildly obese patients, no one's going to care, and you're not going to get compliance. So if you have a patient who's 5, 10, heck, 15 pounds overweight, or what they call mildly obese, which would just be a hair above the 25 percentile BMI mark, we need to talk about, look, this is about you getting better. This is about you being able to do more things and have a higher quality of life. This is not about you having a slimmer waist and looking better in your pants. Like, nobody cares about that stuff anymore. I would love to see a day where that isn't even a thought process registered in the brain, right? Because the idea of what beauty is kind of a joke anyways. So we want to look at health. We want to look at quality of life, and not necessarily quantity of life, because, we're a stick figure, because, we're so concerned about weight, but we don't care about what really matters, which is keeping healthy structure within your organs. So there's that, and I will move on to the next slide. So in coronary artery disease, whenever you have these issues, you will more than likely first get an EKG, and then if your EKG shows that anything's off, or you continue to have this chest pain that you can't really control or is causing you problems, then they move on to an echocardiogram or a cardiac stress test. So a cardiac stress test is pretty simple. For them, they get a bunch of leads put on them, and it monitors them while they have exercise activity. Now, there are a couple of types of stress testing. I'm not going to test you on the types of stress testing. I am going to have you really, really focus in on the mechanical stress test versus the drug-induced stress test. There's one where if you can't physically do activity, they will give you an injection that will basically do the same thing that would normally happen if you were doing some significant activity on an incline, on a treadmill, like the regular stress test does. They want you to wear loose, comfortable clothing for the procedure. The reason for that is if you're wearing tight clothing, it's going to bump on your leads, which is going to give them an inaccurate reading and synopsis, which is not what you want, because they're going to determine if you're going to go on meds based off of this. So, we're not going to do that. The ECG lead placement, again, is better if you have the buttons in the front so it doesn't tap, tap, tap on them. Nothing by mouth after bedtime or 2 hours before the test. You can have water, that's cool, and you can have small sips of water, but they don't want you to do a whole heck of a lot because they don't want you to aspirate because you might have a history of GERD. More importantly, they want to make sure that no nurse on God's green earth gives you any coffee for breakfast because that is a big fat and do not pass go, do not collect $200. You cannot even take this test. We're going to have to reschedule type of a deal. And you want to talk about making somebody angry, give somebody some caffeine for a stress test, and the whole world has just imploded, and the apocalypse has come, and the four horsemen are coming down from the skies as far as they're concerned. So make sure that you don't do that. Wear rubber-soled supportive shoes. Don't wear boots. You're going to be walking. We have to tell patients this kind of stuff because they're going to come in with Timberlands thinking that they're going to do lumberjack cuts, and they're not. We're not messing with Husqvarna chains. All we're doing right now is just walking up a treadmill. So we need some good shoes, like some good trainers. No smoking, no alcohol, again, no caffeine on the day of the test. This inadequate preparation is going to mess up your test. Again, give you a false positive result. Then we're going to end up doing a cath on you for no flipping reason in the whole wide world other than you couldn't lay off the beer at 9 o'clock in the morning. Like, I feel like this isn't even really a discussion that needs to be had, but at the same time, yeah, it does, because it happens. So let's move on to the next slide. All right, so venous insufficiency, huge deal. Chronic venous insufficiency, it is incompetence of the valves in the legs and the veins. It results in elevated venous pressure in the legs. It's very, 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 very painful. You've got edema. You could have a venous hemorrhage or a thrombus. Stasis ulcers are pretty nasty. We're going to talk about that in a second. So the common complaint is not being able to put your shoes on at the end of the day. That is the tall tale sign, the golden technical answer for chronic venous insufficiency. How do you know it's venous insufficiency when you're assessing your patient? Because they go, well, I don't know what's wrong because I'm fine in the morning and by the end of the day, my legs are so puffy I cannot even physically get my shoes on. It's like their foot gets, twice the size as it needs to be because it really does. It's caused by accumulation from standing. A lot of people, so there was a survey that went through and they asked you what was your job and then where did you work and then what did you do in your job. And found that the good news is most people who are nurses, if you wear your compression stockings, and yes, they're very old and unsightly, but if you wear them, you're fine. If you don't wear them as nurses, you might as well be a Walmart greeter who isn't allowed to have a chair and stands all day because it's the same equivalent. Side note, we also have terrible kidneys because we always forget to go pee because we're always worried about somebody else other than ourselves. So yay for being super cool and caring about humanity. Boo for your kidneys being shot. But hey, good news, there's two. So fire it up? Question mark? I don't know. So prolonged stationary standing is the problem. Because blood, it just basically stays and pools, and increases the venous pressure, and increased venous pressure means increased fluid, yada, 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 big fat ankles. There you go. Clients with the venous insufficiency, they're going to have that gnarly brown discoloration. I talked to my Monday class about that, and it's unsightly, and they're usually really, really prominent and really obvious, especially in Caucasian people, because you look down and go, whoa, what just happened? It is that much of a difference in the two, and the discoloration is something you'll never forget once you see it. This is actually pretty classic, this picture that we have here. The capillary leakage is such a big deal, mixing with the red blood cells, which is why it stains. I don't need for you to know what kind of, what it breaks down to, so don't worry about knowing that it's hemosiderin specifically, but know that that is a part of it, but I'm not going to test you on that. That's a little too much. It doesn't have an infectious etiology, so it's not going to be improved by any antibiotic or topical application, so keep that in mind. Where you'll see it and you'll think, oh, is this like cellulitis? No, remember, cellulitis is cherry beet red. It's got heat coming off of it. These legs are cold. These are very, very cold legs because remember, we have venous insufficiency, we have incompetence of the valves, we have incompetence of circulation. So it's not going to look anything like cellulitis, although it will be a bit weepy, it'll be a bit shiny, like that'll happen as well with cellulitis, but you're not going to forget this purplish brown, you're just not. So just make sure that you understand the difference between the two. It's important that you educate your patient on self-care for pain reduction. So wearing compression stockings, taking frequent breaks to elevate the legs, huge, 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 huge deal to fix this problem and to make life a little bit more manageable for them. Because again, it's incredibly painful to have to deal with this. All right, so acute arterial occlusion, it is an absolute emergency. It is arterial occlusion that results from like rupture, thrombus, atherosclerotic plaque that just had too much, emboli from the heart or thoracic or abdominal aorta, aortic dissection, again, acute compartment syndrome from like a really nasty break or crush injury. Chronic AFib. So chronic AFib is notorious for doing this to people. So what you'll see is you'll have a patient with chronic AFib who will have sudden issues with severe pain. Then you're going to check them. They're going to be pulseless or nearly pulseless. It's going to have pallor. It's going to be cold. You are going to freak out because you're going to realize your leg is basically dead. It's going to be incredibly painful for them. They're going to be screaming most of the time because this pain is the most ridiculous pain ever from what I've understood, and I don't even know what that means, but it doesn't sound good. I've seen grown men break into absolute tears, and these guys were tough guys growing up. They were Marines, they were boxers, like the guys that just don't cry. They just say, hey, 'tis but a scratch and keep moving. So, again, make sure that you're checking your signs and symptoms. Pain, pallor, paresthesia, polar sensation or coldness, and then pulselessness. Those are all big baddies. These cause permanent ischemic changes. They cause them quick. So what you need to do immediately when you realize that you got a dead cold leg on you, which is how we reference it, so I apologize for being fairly insensitive, but that is exactly how we establish it, and that's kind of our code name for you need to freak out is when you look at a doc and go, hey, I got a cold leg. They know exactly what that means. What you do not need to do, first off, do not elevate the leg above the heart. It will make it worse, right? This is a venous insufficiency issue. If you push the blood away from the heart or towards the heart, you're pushing it away from the leg. That is the worst thing you can do. Don't do that. Don't walk on it, because what it's going to do is it's going to increase the oxygen demand for that foot. And when you increase the oxygen demand and there is no oxygen down there, then you are going to cause more problems. And don't use compression stockings, because what does compression stockings do? It compresses. So you don't want to compress something that I'm trying to get blood to flow through so that it can perfuse my foot so my foot won't die. Like, I know that this sounds silly. I see this all the time, and it's so frustrating. So we'll get a person, again, AFib, all of a sudden has this crazy pain, screaming, rocking back and forth in bed type of a deal. And what do? We elevate their legs and go, it's going to stop. No, it's not. It's going to get worse. What you need to do is you need to keep them laying flat, because what it does is it stops the oxygen demand at a level of exercise, and it basically keeps it where it's going to keep the demand level to reduce the permanent ischemic changes. So keep them flat. If you keep them flat, you have a basic gradient. That blood flow is perfusing as best as it can. Don't have them doing a whole heck of a lot. Try to keep them out of the sympathetic nervous system. Do all the things. Keep them off of coffee. Don't give them any nicotine supplement. All of the things that are going to cause these areas to get even more constricted or more occluded, or have something that is causing them to not be able to perfuse appropriately. So unlike having a cold leg, When you have a venous ulcer, you are going to do things a little bit different. It's basically the same thing. You're going to have deoxygenation. Blood isn't going to be able to flow from your extremities back to your heart. It pulls, it creates pressure from all the fluid, of all the leakage, and then ultimately it breaks your tissue down, and it happens from the inside out, not from the outside in. So it damages the skin tissue, it leads to the ulcer, which causes a big problem. Now, in this case, unlike our other issue, compression of the leg is essential to healing the venous stasis ulcer. So you have to do that. High dietary intake of protein, carbohydrates, back off of them, right? Prophylactic antibiotics are not routinely used for venous stasis ulcers because, again, they're not an infectious process, just like peripheral artery disease. Most dressings, so any dressings that have moisture on them are awful. So don't even think about it. It's like if you put fluid on an ulcer, or you put moisture on an ulcer, what's it going to do? It's going to break more tissue down. It's going to make it even bigger. And you clearly didn't show up for school that day. So don't be that guy that, does a wet to dry on a venous stasis ulcer and thinks it's going to fix the problem. Because newsflash, it's not. So keep those things in mind for sure. All right, so VTEs or venous thromboembolisms, it occurs when there's a blood clot in the vein. DVT is pretty common. Pulmonary emboli also happens if it gets bad enough. And the DVT happens when the blood clot forms in the deep vein. Usually it's in the leg, but it can also be in the thigh or the pelvis, but usually it's most common in the leg. So for the DVT, you need to elevate the feet to enhance the venous flow from the feet to the right atrium. This is best accomplished from placing 2 pillows up under the lower legs and then 1 pillow up under each thigh. And you do that because when you're laying on a bed, it's a harder surface and you're pinching things. And the last thing you want to do is pinch anything, crunch anything, and encourage anything to break off and turn into a pulmonary emboli, right? So you want to have something nice and fluffy and airy like a pillow. So you want to make sure that you got your feet kicked up higher than your butt, basically. And you want to make sure that you're not putting too much pressure on those thighs so that things don't start breaking apart and gravitating. Placing pillows under the calf or elevating the bed at the knee is going to cause blood stasis at the calf level, which is going to do what? Cause more blood clots. Do not do that. Do not do it. Also, do not put them upside down, okay? Do not lower the head of the bed and think that that's going to be okay and that puts them at the appropriate heart level. No, 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 no. You are putting pressure in the wrong spots and you are asking for trouble. Do not do it. Again, standard procedure is 1 pillow up under each thigh and then 2 pillows up under the lower legs and or feet, right? Lower legs, anything from the knee down. There you go. So treatment for the VTE is Lovidox, which is rapid acting, and then warfarin, which takes a couple of days to prevent the clots. So you need to educate your patient on 2 things, and this is super important. Educate your patient on why they need to do both and why they have to do it at the same time, because they will be non-compliant and go, wait, I got to give myself shots, and I got to take this pill, and I got to go get labs, and I got to go to the Coumadin clinic. What are you telling? And I got to change my diet? What's going on? And they won't do it. But if you go, look, you've got to take this Lovidox for X amount of days, it's usually 7, until this Coumadin starts to do their job. You have to go to the Coumadin clinic and get your INR straightened out, because if you don't, you're going to die, right? When you tell them that, then they start to puff up their ears and they listen. You also need to educate them on the diet recommendations, which is back off of leafy green vegetables. Coumadin plus vitamin K equals bad. That is my math for the day. Write it down. Take a picture. Love it. Understand it. Embrace it. Move along. Okay, let's go to the next slide. So with DVTs, you're going to basically, in the acute care setting, put them on an immediate heparin drip and make sure that you're doing regular blood draws for therapeutic APTT. Now, APTT varies between 30 and 40 seconds. Which is your goal that you're supposed to have. Therapeutic dose of heparin for treatment of DVT is different. So it's to keep the APTT between 1.5, or what they call 45 to 60, or 2.5, which is 75 to 100 times the normal limit, right? So this means that the ATP or APTT value should not be less than 45 seconds or greater than 100 seconds. So if it's greater than 100 seconds, your APTT is too high. And if it's too high, then you're going to have to titrate it back down, or you're going to have to shut it off entirely. If it's too low, then you're going to have to increase the heparin drip, and you're going to have to potentially give them a bolus, which isn't hard to do. If it is with normal limits, you leave it alone. You do not touch it. Do not pass go. Do not collect $200. Your APTT, if it is anywhere from 45 to 100, don't do anything redraw in 6 hours. After you've done that twice and you're still therapeutic, all you have to do is do a blood draw every morning versus every 6 hours. Until you get a therapeutic, you're going to be doing blood draws every 6 hours. They need to know that. Do you ever shut off your heparin? No. You never shut off your heparin unless they are going to the absolute place where they are going to get stented and they are going to remove that clot, or they are going to bust that clot. There is no other reason that you would shut it off unless they discontinued the medication or they were currently headed downstairs, and the only people that are going to shut it off are the interventional cardiologists. There is no other exception. Let me tell you why. In 15 minutes, if I shut off that heparin, it will be as if I did nothing at all. 15 minutes. And it's like they didn't get anything. So they go right back to bad. They go right back to accumulating. They go right back to throwing a clot. Here's why I say this. I cannot tell you how many arguments, and I mean almost in HR, almost getting escorted out by security arguments I have had with nurses, doctors, nurse practitioners who come in and, albeit very nicely, are trying to help, and a patient has to go to the bathroom. So what do? They don't even look at what's hanging. They just unhook them from their IV and take them, say that their nurse is going to take care of them, runs it off to the PCT, makes the PCT go get them, who does not know that this person's on heparin, because that's not their job. Their job is to politely take my patient back to the bed, safely secure them, and then I give them a high five for a good job, because that's what they do, and that's what they're great at doing. So why is that a problem? Because some boobala decided to come over and turn my heparin off, and now my patient is going to go right back to maybe getting a PE and dying because of ignorance, and because we can't be bothered to look up. We can be bothered to have to deal with somebody as we try not to roll our eyes because they have to go pee because we're throwing fluids and heparin into them. We can do that, but we can't be cognizant as a physician who literally wrote the order for the heparin to realize that heparin is running and they cannot take them to the bathroom and unhook them. Because guess what? Most people take longer than 15 minutes to go potty. You know, it's a thing, especially with older people who have peristalsis issues. So that is my rant on that. And if I rant, it's usually because it's so serious, it's going to be in the big 3. And if you notice, I've done a whole lot of ranting. So there you go. Take these things into memory. Commit your levels into memory, please. All right, I'm done talking about this. Let's move over. Now, Raynaud's is kind of a wicked deal. Raynaud's is a phenomenon that happens when the fingers and the toes start to accumulate symptoms and they get a vasodilation and a vasoconstriction at the same time. It's pretty wicked. Typically caused by underlying disease, but it can occur by itself spontaneously. You have to teach the client the basic things. So if you notice over in this picture, they've got normal pink fingers and then they've got white fingers. White is not good. If you notice those nails, they're looking a little blue. Not good. They're definitely vasoconstricted. So we need to let them know some things. And first thing we need to educate them on is do not, one more time, do not put anything hot on those hands. Because guess what? If your hands are white, like that type of white, and you have vasoconstriction, you are not going to be able to feel your fingers very well. And if you put heat on them, you don't know what type of heat, and you will burn yourself. I am not being crazy. I am not being over exaggerative. This is exactly what happens with these guys. Raynaud's is very, very uncommon. I think I've seen it in probably, in 10 years, I've probably seen it in less than 50 people. So it's not very common, but it's common enough to where it's a thing. So make sure that you watch out for these. No heat. They're going to burn themselves. It's completely common for them not to be able to feel anything. No Sudafed. Sudafed's a vasoconstrictor. Can't do it. It's okay to do NSAIDs for pain management. I used to hear that NSAIDs were a big no-no for Raynaud's. It has nothing to do with Raynaud's whatsoever. It is completely okay to use NSAIDs. Keep that in mind. Caffeine, nicotine, no, 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 no. Obviously, they're going to cause more vasoconstriction. It is a big fat no-no. Teach these guys, if they're going to exercise, do not go out in the cold. Keep in the hot area, and by hot, I mean normal temperatures, but not scalding. And don't put, what are those little packets that are like heat packets? Don't put those in your hands because you're going to burn yourself. Because remember, if your skin is desensitized, it doesn't have to be 115 degrees to burn you. It just has to be hot enough for your skin to realize that it's going to get damaged, right? These are all about hormone signals. Some people can hold really, really hot things because their brain tells their body that 180 degrees isn't a bad deal to hold if you hold it for a few seconds. However, white fingers get that same receptor and go, yeah, I'm going to be able to have a threshold of about 90 degrees, and then I'm going to start to go ahead and cause damage. So you can't do that. You can't expect that that's going to be a thing. Even things like a heating pad can burn a person if it's not watched well enough. All right, varicose veins. Every nurse's total fear in this world. So varicose veins, they are dilated. They are tortuous, which means they're squiggly. They're superficial. They cause significant symptoms. They are heavy legs, itching, burning, throbbing, cramping. Legs are completely restless. It is miserable. I'm terrified of getting these things. So far, I've managed to not in my beautiful almost 40 years of my life. And I hope to God I don't get them. And if I do, I'm going to get them zapped out. And I'm going to talk about that procedure here in a second because I'm super excited about it if it happens because I will no longer have that problem. Symptoms are due because there's incompetence of the valves of the veins. It results in pooling of the blood. It increases the pressure in the legs, and again, they pop open. The discomfort is because it's varicose veins, and they're going to be uncomfortable. And when you elevate them, it relieves the pressure because the elevation decreases the venous pressure by promoting the blood to return from the legs to the right atrium. So again, the tall tale fix on this is to elevate your legs and back off of them. Now you're going to have improved varicosity and varicose veins with walking and improved pain and discomfort because every time you're walking, you squeeze those calf muscles and the veins promotes the return of blood to the heart. So the more you walk on them, the better it's going to be as far as your pain level. It's not going to change the fact that they're squiggly and they freak you out if you wear a dress, but it's going to feel better. So keep that in mind. Make sure that you're educating them. They have to have movement to get it any better. And then when they have breaks, they need to elevate their feet immediately. It is not worse when a person wakes up. That is a common myth. I don't know why they would think that that was a thing. I remember hearing that in nursing school, and I thought, well, why would that make any sense at all? Because if this is a problem that is exacerbated when you have your feet down or you're laying stagnant or you're standing all day, why would it make any sense? If you're laying flat, that would be the perfect alternative to not be in any type of pain. So it's the opposite. When a person wakes up, they are not that much in pain. And then as the day progresses and they forget to kick their legs up, they continue to have worsening pain. So make sure that they've not been, or they don't keep into a dependent position during sleeping or when they're trying to relax. If they keep their feet kicked up, that's great, but they need to have it above the level of the heart, which is the bigger thing that we need to be teaching them. And wearing stockings alleviates throbbing and pressure. So they have to wear those stupid Ted hose that they hate. And most nurses, even the most beautiful nurses in the whole world, you look at them and go, oh my God, look at that wonderful hair. Look, they're all put together perfectly. Look at that shiny, bright face, that perfectly like coiffed beard, right? Those wonderful eyelashes that she just got put in. And then they have the most 80-year-old thigh-high socks up under those pants. And it's the most girdly, like old Myrtle looking thing you've ever seen. But you know what? We don't get those bad boys on us, and I'm proud to say that I do not have those because they look absolutely terrifying to me. So keep all of those things in mind. Those things are going to come back in the big three. They always do. All right, so let's talk about sclerotherapy. It's exciting for me. So if I do get one of these, it basically is a process of injecting liquid or a substance that scleroses directly into the vein. So it is an intravenous injection that they give you technically because duh, it's in your venous system because it is a varicose vein. So they put this stuff in there and then it causes the endothelial inflammation to basically destruct the vein, which disintegrates the vein. I mean, it happens, boom, that fast. Like, it is wicked. YouTube it if you want to. YouTube varicose vein procedure, and it literally looks like it just zaps it away. Like, it explodes and zaps. And that sounds super scary, but it's not. And I know people have had this procedure done, and they said it was just a game changer for them. And I am terrified of very few things in this world. Varicose veins and the pain that's associated with them is one of them, and the other one is shingles. And there's not much in between. Ebola, I got a 92% of dying within 72 hours, so can't really get worried about that. But these guys, you got to live with it for the rest of your life. That is scary to me. So there you go. It is performed on an outpatient. You are not under anesthesia. You are under a local lidocaine anesthetic if you really, really want to, but you don't necessarily even need it. And that is the brunt of what that looks like. So make sure that you understand it is an intravenous injection, so you need to make sure that your patient is aware of that. But as far as being intubated, being under anesthesia, this, that, or the other, downtime, like, it's not a thing. It's an outpatient. You're in and out in about 45 minutes, and you come out a new person. I think that's fabulous. Okay, so peripheral artery disease, it's fairly common. It's narrowed arteries, which reduce the blood flow to the arms and the legs. In peripheral artery disease, the legs, the arms, but usually the legs, don't receive enough of the blood to keep up with the demand that it has. So the common, most standard textbook symptom that you're going to get is prolonged capillary refill in the toes. Is the most common sign and symptom. So they have what's called claudication. Claudication is kind of a wicked concept. And I've known a lot of people working with interventional cardiology and vascular surgery over the years and in residency who have had these issues. And claudication is a process that it hurts when they walk, period. So full claudication is anytime they walk, it's excruciating. And then they have what's called intermittent claudication, which is common sense because intermittent means in between, right? So here's what they say. They say, I was good walking about a block and a half, and then I thought I was going to die all of a sudden from the pain. And then I stopped, and then it stopped. So then I walked some more, and then I was fine for a little bit, and then it came back. And then I couldn't move, so then I stopped, and then it stopped. And it's just this vicious cycle, right? Whenever you have a suspicion of any type of claudication, be it normal, just full-on claudication or intermittent claudication, you have to check dorsalis pedis, you have to check posterior tib, because these are going to be direct indicators of this process. And these guys need sometimes immediate intervention. I mean, these legs go dead really quick. They become ulcerative if they get bad enough. Your legs go nearly black. I mean, it's a bad deal. I had a guy who was really, really sweet, and he was a banjo player for a folk group and a grassroots group. Super cool guy. fairly famous in that genre, if that's even a thing. So I went to go look at him. He took off his shoe, and I thought his foot was going to fall off with it because he was in such a progressive state of having this type of full-on claudication, and he had a cold leg, like all the common things that you would expect. So you got to check these pulses because sometimes you're going to have to schedule surgery that day, which is what we had to do with this gentleman, and we were able to save most of his foot, which was pretty exciting. Peripheral artery disease is usually a sign of a buildup of fatty deposits or atherosclerosis. What we need to do is understand that the medication regimen and treatment for this is statins, because it improves multiple outcomes of the disease process and is a gold standard for the treatment itself. So statins do a lot of things. It decreases your ability to continue that plaque buildup by way of, having those lipids busted, right? So Lipitor is a normal statin. Lipid is a fat, so the name is literally in there. So make sure that you understand that the statin is going to be your gold standard. Know that atherosclerosis, which we talked about earlier, causes the narrowing of the arteries. It's going to reduce the blood flow of the legs, sometimes the arms. And PAD treatment is exercising, eating a healthy diet, not smoking, not using tobacco, all the things, right? So when you have a patient that has peripheral artery disease, here is your education. And I have hashtag duh no smoking, because duh no smoking is something you would think that they would get. Nah, not so much. So make sure that you wear loose clothing, that it doesn't bind across the legs or the waist, because what would that cause? That would cause constriction, which will help with the occlusion, which is a bad thing, right? So walk to the point of pain, and just hang out with me for a second. Let me explain this one. Walk to the point of pain, rest, and then walk again for 30 minutes 3 times a week. This is a real thing. So I just happen to know and happen to have worked with and happen to have one of the coolest mentors and godpapas in the whole wide world. His name is Barry George. He is world renowned, and he is an interventional cardiologist, and he is super duper cool. He's like 67 years old now. He's a legend. He used to engineer catheters, like he would design them, that would go into people, and eventually decided he didn't want to be an engineer anymore. He wanted to go to med school. Bing, bang, boom. Here we are 40 years later, and the guy has saved several thousand people. He's nuts. So I think the funniest story he ever told me was when he was getting pulled over by the police, and he kept going. He's got a 68 Stingray that he flies through. He parked into the front of the emergency room, which is where he always parks, and he's allowed to because he's flipping Barry George. And he jumps in, throws his lead on, walks into the cath because there was an acute MI, and he was flying 116 miles an hour down the road with this cop behind him. The cop threatens to tase him, threatens to shoot him. He keeps walking. He goes into the cath lab, and the guy sees the patient opened up on the table and vomits and leaves. And that was one of the funniest stories I think he ever told me. And he's got 1,000 crazy stories because he's a crazy type of dude, but the sweetest guy you ever met. So I say all of these things because I had a patient who had many, many vascular stents because of claudication. And he finally said, you know what's the only thing that's going to work? Because it's not these stents. Because your stents keep breaking, they keep malfunctioning because these things are so closed up. What you have to do is you have to walk to the point that you can't stand it anymore. Then give yourself a 5-minute break, then do it again. Because by you doing that, you were squeezing and encouraging those guys to start pumping again like they're supposed to. Remember, when we walk, we squeeze. We squeeze everything back where it's supposed to go, back to the core of the system, and then it comes back around and recirculates. And this is how the body works. So, as terrible as that concept sounds, you absolutely have to believe it is a thing. It is going to work, and it is the only thing that's going to work when you have this significant problem. And again, it is extremely painful. Do I know how extremely painful? No, but I know what it feels like to cross my legs or sit on my feet and then get off of my feet after I've studied for 5 or 6 hours without moving, because that's just what I do. And then I go to stand, and it's that awful pins and needles feeling. I've heard it's like that, but times 10, if that puts things in perspective. So make sure you let them know how important that is, because over time, and I mean 3 to 6 months time, they will have significant improvement in their ability to move. Their level of pain will go down, their quality of life will go up, and it's a good deal. Okay. Make sure you're changing positions every hour. Avoid long periods of sitting on the legs crossed, which is what I just told you that I do. So don't repeat it to anybody, specifically Barry George, because he will be up my butt one way and down the other, and I don't want to hear it. Do not use heat to improve circulation, quote unquote. This is not a thing. This is a huge myth. Again, it's going to cause burns much like it would with Raynaud's, only it's going to do it worse because it's more sensitive on the legs. It's easier to burn your legs than it is your fingertips that are used to feeling hot things because you've been cooking for most of your life. So keep these things in mind. Do not use heat to improve circulation. That is not a thing. Okay, let's move on. All right, so let's move on to hypertension. So hypertension is high blood pressure. Newsflash, no, Devonna, that is not a question on the test, and it is not an answer on the test. So I'm not giving you any answers to the test. There. Okay, you guys, my PM class is going to be laughing pretty hard on that one. I thought that was pretty good. So if you have high blood pressure, the force of the blood pushing against the artery walls is consistently too high, right? So that's why we have the high blood pressure. So it has to work harder to pump the blood when you're dealing with hypertension. So if it's untreated, it's going to increase the risk of a heart attack, a stroke, other serious health problems. It's important to have your blood pressure checked at least every 2 years, starting at the age of 18. As you get older, you have to do that more frequently. Once you start to have hypertensive issues, then obviously you have to monitor it more. Improve your healthy lifestyle habits. Don't smoke, exercise, eat well. Easier said than done, especially when you're a nursing student. You want to do all three of those things. I get it. It's okay. I'm right there with you, brothers, sisters, and non-binary friends. It's okay to feel that way right now. It's not always going to be like that. Know that it can help and prevent and treat high blood pressure. Some people need medicine to treat high blood pressure. That's pretty obvious. Take heed to these symptoms of high blood pressure: blurry or double vision, lightheadedness, fainting, fatigue, headache, heart problems, and palpitations, nosebleeds, shortness of breath, nausea, vomiting. If you have persistent headaches, that is a direct indicator of having hypertension. So if you ever hear someone complaining of persistent headaches that go on for weeks at a time, you need to get them to the doc ASAP, because they probably need an antihypertensive. Okay, so let's talk about the blood pressure categories, which you are absolutely going to have to know on the big three. I'm just letting you know you need to memorize the chart, memorize the chart, memorize the chart. Said it 3 times. Y'all know I love Nikola Tesla. He does things in threes. So do I. So normal is less than 120 systolic, and then diastolic is going to be less than 80. Elevated is going to be 120 to 129. Now we got stage 1, which is 130 to 139. We got high blood pressure, which is stage 2, which is 140 or higher. And then hypertensive crisis, which is higher than 180. Let me make this perfectly clear. When we go from stage 2 to full on hypertensive crisis, or when we go from stage 1 to stage 2, when it says 140 or higher, it literally means 140 or higher. So if you are 176, 178, you are not in hypertensive crisis. You are in stage 2 high blood pressure hypertension. Please understand that. So if you are at 179, if you are at 180, it does not matter. You are not hypertensive crisis until you get higher than 180. And if you get higher than 180, you better be running to the hospital as fast as you can. And if you are a nurse and you see someone, and their nurse or your PCT technically goes or casually goes to you and goes, hey, that pressure is systolic, it was like 182. I want you to go fix it and make sure that that's the right blood pressure, because we're going to talk about what happens when people do blood pressures wrong, because I feel like I need an entire slide dedicated to people that don't know how to take a blood pressure, but their entire job is to do vital signs, whatever. We'll get into that later. Nurses do it too. It's so annoying to me. So make sure that you understand that, because if you have a pressure that flops off like that, and a lot of times your techs won't tell you, so you have to stay on them about it, because they don't know sometimes, because they're brand new, because everyone's brand new now since COVID happened. make sure that you are watching those numbers and make sure that you are recognizing if that is a real thing or if it is a fluke. And I will explain what flukes happen with blood pressure cuffs and why they happen. And then maybe that'll give you a little bit of insight on how this works. Now, as far as this chart's concerned, bottom line is you got to memorize these. Like full on out, it's always going to ask you this stuff. This is a standard by the American Heart Association. This is a standard by CDC. This is a standard by your NCLEX and your HESI, and it's going to be on the test. There you go. It's going to be there. Study it, know it. It's on the big three. It will always be on the big three until the end of time. All right, so when you're dealing with hypertension, we're going to talk about the regimens that we're going to have to deal with. So when you're in stage 1 hypertension, diet modification is a big deal. Dietary sodium, keep it to 2 grams. Fat modification, and then recheck your blood pressure in a couple of weeks once you've done those things. So the whole point of a doc who is dealing with new hypertension is to recognize that it's going to develop into a problem and know that hypertension isn't really a problem until it starts shutting down organ systems, right? When it starts attacking the organs, that's when we start having a big problem, and it's irreversible. Before then, there's a lot of variance where we can tweak what your hypertension truly looks like by way of, again, dietary sodium, fat modification, and then rechecking that blood pressure in a couple of weeks. And 9 times out of 10, usually you're right below that threshold of being a stage 1 person at that point. Now, when you get to stage 2, you have diagnosis, treatment, and modification needs. So what we mean is diet modification, dietary sodium, treatment by way of medication, because it has to happen, because it cannot be done alone once you get to stage 2, and then having a formal diagnosis so that we can continue to do your regimen, okay? So when you get to hypertensive crisis, again, do not pass go. Do not collect $200. Take your butt straight to the hospital. You will be hospitalized immediately. They will be giving you some serious antihypertensives, and we're going to get into the types of antihypertensives. There's quite a few, but I'm going to hit the big players that always show up on the big three so that we all understand. Whenever you have a sudden increase in blood pressure with a patient who's like 50 years or older and doesn't have any hypertension issues, no history, no risk factors, then we're not necessarily looking at hypertension. Please understand this. Just because they're older and they fit the criteria, if they have no history at all, that this might be something that needs further investigation. This might be a medication issue. Some medications will increase your blood pressure, right? So we take certain medications for certain things that might have nothing to do with blood pressure. Meclizine, midodrine are two obvious ones that I can think of. Midodrine is traditionally used for dialysis patients to increase their blood pressure, but we also use it for people with chronic migraines sometimes. We use it sometimes for people who have orthostasis. So we're going to use it for things other than 100% blood pressure related, because orthostasis has a lot of other things that are proponents and have reasons that aren't necessarily hypertension related to produce that type of result. So meclizine is for vertigo, and again, meclizine potentially will raise that blood pressure. There's 1,000 medications that raise your blood pressure. So just, let's see, if pseudoephedrine or Sudafed will do it as well. So just keep those things in mind. We might have a bigger issue. It might be a temporary deal. It might be because they're sick for the time being. So we have to investigate it. We can't just put them on antihypertensives, because then they're going to conk out and they're going to end up in the hospital. Blood pressure will need to be treated and ongoing with monitoring if it's stage 2. Stroke is the immediate future if your systolic blood pressure reaches higher than 180, not 180 or higher. Let me say 181 or higher. I'm going to fix that right now. There you go. And then you must seek immediate medical attention if systolic blood pressure is greater than 181 again. All right, cool. Dietary salt or fat intake will not be a contributing factor in sudden increase in blood pressure. Please understand that one. You absolutely need to understand that, because, again, we go right back to the 50-year-old guy we were just talking about. It might not have anything to do with anything other than a medication change that they had. I know a lot of antidepressants will also increase your blood pressure in a lot of ways. So, again, salt, fat intake is not going to be a contributing factor if it is a sudden acute change. If it is a chronic change that gradually changes over time and then you get to the point where it's so bad, okay, cool. That probably has something to do with those factors. If it's acute, nobody, we're missing something. Reducing intake of salt and fat alone will not be adequate to reduce stage 2. Which I think I mentioned about a minute and a half ago. So that's all I have for this particular slide. Let's move to the next one. All right, and like I said in the last slide, hypertension is usually asymptomatic until the target organ has occurred. And once it's damaged, at that point, it's mad and it's going to continually fight to get better, but will continue to deplete itself, lose energy, and more than likely get worse if you don't get treatment. Lifestyle changes are used to help manage blood pressure, but drugs are needed for these patients at this point. Some blood pressure monitoring should be taught to the patient, and finding that they need to have it checked by a healthcare provider frequently is very important. Once they get a baseline, then they can see the doctor every 3 months. But until then, they're going to be seeing them pretty frequent enough, and they need to be doing these pressures at home and keeping a blood pressure diary because we need to see what that variance looks like. When I see a patient, I could see them and their blood pressure could be off for an innumerable amount of reasons. One that I can think of is white coat syndrome. We're going to get into that in a second. Another one is being super stressed out, or maybe you just got into an argument, maybe you just found out you lost your job, those things. Maybe you are having a little bit of depression because, you miss one of your family members that, passed away recently. There's a lot of things that can have anything to do with this. So you need to make sure that you have a good outlook of what the 3-month category and spectrum has done. And then at that point, I'll start messing with medication. So once I see the diary, you'll notice that a lot of them are going to be in between the 140s and 150s, and that's going to be most of the blood pressures. You'll also see it spike, and you'll also see it decline at certain times of the day. I usually see nighttime blood pressures go lower, and then around dinner time, I usually see them at the highest because that's when they're getting off work, they're complaining about work, they're thinking about all the things that went wrong at work, and those things will stress them out. Kids are going to be screaming, "Mom, I'm hungry. Daddy, I'm hungry. Help me with my homework," and those things are pretty stressful. So that's probably why we had that spike. And then towards the end of the evening, they're about to go to sleep. They're finally relaxed. Kids are asleep. They can finally hear the sound of silence, which is the most wonderful thing in the world. And, there you have it. The blood pressure is better. So the increase in physical activity does not usually control blood pressure itself. I'm going to add the word activity because physical isn't enough. I-V-I-T-Y, and that spells activity. Cool. If a patient is in a hypertensive crisis, which is systolic blood pressure of 181 or above, and has an inability to move a limb or multiple limbs, this is probably a stroke. So if a person can't move and their pressure is that high, we have a problem. They need immediate action. They need to prevent further neurological damage and ischemia. You must notify your provider that second. If they cannot move one side of their body, that's more than likely what we're dealing with, especially if they have these nasty high pressures. Now, I had a student on Monday ask about permissive hypertension, and that was a phenomenal question. So good on you, and you know who you are. So permissive hypertension is when we actually encourage high blood pressures, and they can get up to 225 systolic. Now, calm down for a second. This is after a patient has had a confirmed stroke. It is an ischemic stroke. It is not a hemorrhagic stroke. If you have a hemorrhagic stroke with that high of blood pressure, you're going to kill them because that brain bleed is going to spread. And since it has nowhere to go because skulls have sutures that are closed, they will die by way of torturing their brain stem, okay? So that's not good. But when we have an area of ischemia or lack of oxygen, we want to bathe that area in blood because we can actually recover most of that if it's done within a fair amount of time. We can actually recover most of that by way of an alternative method, that I won't even get into until we get into neuro. But when I do, I'm pretty excited about sharing it because you guys can actually save a person's life and save their function and recover function lost from a prior stroke just by being you. I'll just put it that way. Just by being you and giving them 5 minutes of your time. How about that? So moving on from that, you're going to have extreme headaches, decrease urine output, tremors when you're related to or when you have these higher blood pressures. But remember, the important assessment findings should be addressed with the provider as soon as possible. So the bigger deal between extreme headaches, decreased urine output, tremors, to me, is this horrible pressure and your inability to move. So please understand prioritization, because a lot of people will be concerned about the PN factor and not care about the fact that this person can't move on one side because it might not be enough of non-movement for them to not know what's going on, right? And they might be looking at I's and O's at the Epic computer and maybe not checking their patient every hour like they're supposed to. And their text says, hey, they're not moving right. And they go, they're probably tired. They're old, right? Like that happens a lot because that's reality. And you need to know about what reality looks like and know that that's not what you should do. And you need to go assess your patient immediately. Because the other things, extreme headaches, they have hypertension. That's a thing. Decrease urine output. Yeah, your kidneys are pissed because you have really, really high hypertension. And tremors, when you extend your hands out and your pressure is ridiculously high, they're going to shake and tweak. That's normal. What's not normal is not being able to move your body. Please understand that. All right. NSAIDs, they can prevent adequate blood control or blood pressure control. So you will have to figure out what to do as an alternative method for pain management or arthritis management, because NSAIDs are no-nos when you're dealing with this. You have to stay away from them. And a lot of times you will have hypertensive dosing and they will keep increasing it. And this is why we say, what other medications do you take? Because if we know you're on NSAIDs, we know that this is going to mess up the effectiveness of our medication. So I might keep you on NSAIDs, but have to double your medication. So you've got to let these people know. But for the most part, we want them to just avoid the NSAIDs altogether. So please understand that. Please commit that to memory. All right, so we're talking about hypertension. We're talking about another diet. It's the DASH diet. It is basically increasing the intake of calcium-rich foods is the ideal and the goal. It is the diet approaches to stop hypertension is what it stands for. So milk is an excellent source of calcium, but we need to make sure that it's low-fat milk, and we need to make sure that it's a glass a meal to meet the recommendations. So please understand when we're educating them, if they say, hey, I want to do a glass of milk, make sure that they understand it's low fat, make sure that they add in the fact that it's for every meal, and then we're good. Caffeine restriction, decreased protein intake are not part of the recommendations despite popular belief. So everyone thinks that because caffeine causes vasoconstriction, that this is going to be a proponent to increased hypertension. And while I do agree with that thought process, we're talking arterials versus venous. So this is going to be a different type of deal. So caffeine restriction isn't really a thing. Decreasing your protein intake, I don't even know where that came from. That doesn't even make any sense to me logically. So they are not part of the DASH recommendations. Please understand that. Nuts are high and beneficial in the nutrients, and 4 to 5 servings a week are recommended in the DASH diet. Although it's not a great source of calcium necessarily, it is important to get those appropriate oils and fats and proteins. So please make sure that we're also educating them about that. Chicken and fish are great sources of lean protein, but should be limited to 6 ounces per day. So 6 1-ounce servings is how they have it written down. Make sure that we understand that that isn't necessarily going to be incredibly effective, but that is going to be our limitation, is that 6 ounces and no more for sure, because you might run into other issues. So yeah, I think that's all I got for this slide. All right, so this slide, hypertension, is it really though? So these are all of the things I have ran into in the last decade of my life that I run into often. And when I say often, I mean 2 or 3 times a week often. I might even be lying to you. It might be even more than that. So First off, nurses, techs, doctors, respiratory therapists, code team people, rapid response people. Guess what? On every single cuff on the inside of the cuff, there's an artery line. It literally says artery line. It is in red. It has a circle around it at the bottom. Pull up a cuff, look at it. Every single cuff on the entire nation has got this thing called an artery line. Guess what goes on it? The artery. Guess what does not go on it? Anything other than the artery. So let me tell you what happens. I've got a tech, I've got a doc, I've got a nurse practitioner, I got anybody that will get the biggest cuff possible and will push this cuff all the way to the side and throw it down, and then it will beef up, and then it'll stop and beef up even more and continue until the patient is screaming because it hurts so bad. And then I've got someone coming to me going, their pressure's high, you need to give them a PRN medication. And I go walking in there and I look at my patient. My patient doesn't have a red face. My patient isn't complaining of a headache. My patient is looking at me going, hey, what's up? And I'm like, are you feeling all right? And they're like, yeah, why? My arm's hurting like hell. Okay, cool. Can I check your blood pressure, please? And they're going to be like, please don't, because somebody else just did. And I'm like, nope, I'm going to do it on the other arm, and I'm doing it the right way. And then you magically stick that perfect little artery line on the artery. And then guess what happens? Their blood pressure is 138/64. And then I casually walk out and I go, did you put the artery line on the artery? And they go, yeah, I did. And I'm like, let me show you how this works. So every blood pressure cuff, if you extend it, it will say this line means it's too big, this line means it's too small. So you have to first give them the right size, much like you have to have the right size shoe. If I have a size 10 foot, which I do, I cannot wear a size 13. I can. I'm going to look like a clown. I'll be able to ski on water, but it's not going to fit me and it's going to fall off, much like a blood pressure cuff that's too big or too small. So what happens is when you put that artery line and then you rotate the rest of the cuff around and you stick it to the Velcro, if that artery line goes over that second line, and you'll have to look at it to see how it works to understand what I'm saying, that will indicate that that is the wrong size. So you will either have to go down a size, which is usually what happens, or up a size, which is also what happens. So make sure you've got that right, because if it's too tight, it's going to give you too high of a pressure. If it's too loose, it's going to give you too low of a pressure. You got to be Goldilocks and get that perfect like shade of porridge, and then it's just right, okay? The patient should be seated with the feet flat on the floor. They cannot have their legs crossed. They cannot be talking. Listen, guys, I work neuro ICU. I've done this for the first 7 years of my life. So I am psycho about blood pressures specific to strokes, because what am I watching out for? Hypertensive crisis, because what do I see with hypertensive crisis? Massive stroke. People die. I don't like it. I like people living. It's fun. So please make sure I'm not talking while I'm taking this pressure. I'm not crossing my legs, and I'm not squeezing my arm because I've got borderline personality disorder and my mom and dad are kicking me out of the house, and I want to make an excuse to make them feel bad so they'll keep me there, because that also happens, okay? If the blood pressure is obtained in both arms and recorded, it's got to be recorded as two separate pressures. Back in the day, a billion years ago, like literally 60 years ago, we would do two pressures and then we would average them together for a centralized pressure. That is not a thing anymore. It no longer exists. It hasn't existed for a while. It was a terrible idea to begin with. If you have significant changes on your blood pressure on your left arm and on your right arm, and I mean it's usually 20 or more systolic, that is an indicator that you have a subclavian occlusion. That can kill a person. That's a big fat yikes. That basically lets you know that something is stopping the pressure on one end and is increasing it on another to a point of no return. It has to be looked into. You have immediately got to notify your physician, okay? So the results of the two are not averaged. Never know how, not going to happen. We usually do two for a brand new patient, okay, because you need to make sure that you understand that both sides are appropriate. Obviously, you shouldn't do it on one side if they have a mastectomy. You need to have a limb alert on them, yada, yada, yada. Patients should never be laying flat unless you're doing orthostatics and you're starting them, because if you have a person laying down flat, they're going to have a lower gradient of pressure. It's not going to be effective. You're going to get the wrong answer, and then you're not going to give them meds when they do need them, or vice versa, and give them too much. So the cuff should be deflated 2 to 3 millimeters of mercury per second. Any more than 2 to 3 millimeters of mercury is an inaccurate result. So don't squeeze, go your 20 over, and then just pull the receiver and, go ahead and loosen it all the way up, and then it goes, and then your gauge just pops down. Because at that point, you won't have an effective reading, okay? And also, don't keep it blown up and barely dial it down. So I've seen people that blow it up to like 220 because that's just their magic number. Blow it up to 220 and then barely loosen off that gauge, and it's like, gunk, immediately, because you are not releasing enough pressure. So you've got to make sure you're doing that right. And you should never really trust a monitor, especially with a new patient. I never trust a monitor because monitors are usually wrong because people don't put the artery lines on the artery. Oh my God, it's so annoying. And then I have to yell at them. And then they look at me like I'm a crazy person. And I'm like, you know what's crazy? Not knowing how to do your job, because it's literally your job to do this, because I'm over here worrying about other things besides making sure you know how to put an artery line on an artery. Oh my gosh, it's so annoying. Okay, I'm done. All right. Make sure that you also get an accurate baseline blood pressure for the new patient, because that's going to dictate what's going to happen for future. And we need to keep a good track on that, because in 5 years or 2 years or 6 months, something might change and we might have to look into that. So keep it in mind, please. All right. So again, when we have newly diagnosed hypertension, we need to let them know that preventing hypertension or reducing hypertension includes exercising aerobically for 30 minutes most days of the week. Education on exercise is the most important lifestyle modification to address to a patient, okay, when you're dealing with new diagnosis, which means the hypertension isn't significant. Being excessively overweight is a risk factor for hypertension. Being a couple of pounds overweight is not a risk factor for hypertension. Let's not scare our new patient. Let's not freak them out and tell them they need to lose weight. This is not a matter of weight in this situation. 5, 10, even 15 pounds is not going to significantly increase my hypertension. So we do not need to fat shame people because they had a little bit more on the holidays to eat than they normally would, or they're, farty and bloated because they're a female and it's their time. Like, don't be a jerk. Don't be a jerk, right? Like, just don't be that. Don't be that guy. Don't be that girl. Don't be that individual. Okay? Just be sweet. And make sure that you're focusing on what's important, because if you tell someone they need to lose 5 pounds right now or get out of my office, that's not going to work very well at all. And it's not going to do anything for them anyways. Make sure that they understand that the DASH diet is a high in fiber diet, but increasing fiber alone is not going to prevent hypertension from developing. Alcohol intake, it is not going to increase the hypertension risk if done in moderation. If you overdo it, obviously that is going to affect your blood pressure, but if you have a beer or glass of wine at dinner, that is not going to be a significant risk factor increase in hypertension. So keep that in mind and commit that to memory as well. All right, white coat hypertension, it is a thing, I swear. Patients get elevated blood pressure when they're in a clinical setting because they get nervous. And then if you measure it anywhere at home, they're fine. It's so bizarre. I've seen it. It's a real thing. It's just like Takotsubo, which is this heart condition. It's called broken heart syndrome. When someone is so upset about the death of, whatever, or a separation of people, or the loss of a child during miscarriage, like whatever the deal might be, these people have these broken heart syndromes and they die from it. They really, really do. So remember, whatever you tell your brain to tell your body, it listens. So we got to be cognizant of that. So white coat syndrome, it's very, very similar in a lot of ways. There's really an insidious onset. Some people are just naturally nervous around people. If you notice, I don't wear a white coat to any of my clinicals. I don't wear a white coat to any of my lectures. What am I always wearing? The same pair of scrubs that you guys always see. Why? Because A, it's incredibly efficient and it's an intelligent move to wear the same thing every day because I don't have to think and I can focus that thinking on more important things like how the heck am I going to get my people through the semester? Or I wear nothing else at all. Now, I do flash my shoes. You guys are well aware of this, but I keep it that way because I also don't want you to feel like I'm hierarchical, right? I don't care about what your status is. I don't care about what your stature is. I don't live in this brain of a caste system. It's not a thing where I come from. It will never be a thing in the Native American community. There are no like higher than people. So I'm going to look at you just like I'm going to look at somebody famous, just like I'm going to look at somebody who's homeless, right? And that's just what I do. Unfortunately, that's not a thing, and other people will see that white coat and think that for whatever stupid reason, I matter more in the world, which I don't get either because I absolutely do not, and I'm the first one to tell everybody because I'm just like everybody else. They will freak out just because I represent what I represent. And they think that I'm going to be the bearer of bad news to them. And until they get to know me, that's what's going to be on their brain. So they are going to have these problems. And what I have to tell them as a provider is go home, monitor your blood pressure at home, write it down in a book, bring it back to me, let me look at it. And if I see that those numbers are fine and I have a spouse that confirms it and it makes it even easier for me, then I know it's okay. So at that point, I just do regular blood pressure checks in the clinic and realize that they're probably going to be higher than they're normally going to be at home. And when I say higher, I mean some of these get into the 150s, 160s, and then they go home and do it themselves, and by the time they're home, they're in the 120s. I mean, it is that significant. So please understand there's no evidence of elevated stress levels or a poor diet that contributes to white coat syndrome itself, okay? So because I'm stressed about what happened to my mom 4.5 years ago, is not the reason I'm getting white coat syndrome coming into the door, okay? And having a poor diet, there's no significant contributor to that whatsoever. So it's not the fact that I'm physically wearing a white coat. It is the idea of what that white coat represents and the uncomfortability of me being in that environment and the anxiety related to that, not an elevated stress level about being in there. Does that make sense? I feel like that might not make sense to some people. So elevated stress levels got nothing to do with it. Anxiety related to the environmental trigger, that is a thing, okay? So please make sure that you got that separated in your head. All right, let's talk about the 9,000 hypertensive medications or antihypertensive medications we have. Lisinopril is very common. So it's a class of medications that are the angiotensin converting enzyme or the ACE inhibitors. It works by decreasing certain chemicals that tighten the blood vessels so blood flows smoothly and they can pump more effectively. It's also used to improve survival after a heart attack. People who get lisinopril are at risk for developing angioedema. It causes swelling in the throat. If they have swelling of the throat and complain of swelling of the throat, I don't care if it's for 5 minutes, I don't care about for four hours, or if it's for 2 days. It is an emergency. The patient experiences symptoms. They have to have immediate follow-up. So if you find out these people are having this problem, you better call a doc that second because that is a problem. That is a reaction that we were not hoping for, okay? Clients will habitually have dry mouth. They'll have dry throat. They're going to have a hacking cough. They're going to tickle in the back of their throat. It's going to annoy them. They're going to hate this medication. This medication, 9 times out of the 10, you're going to start with lisinopril, think it's a great idea, realize that you made a terrible choice, and you're going to change it the next time you see them because they almost always complain about this problem. As much as people complain about statins and it causing massive leg cramps, you're going to hear them complain about lisinopril and a cough and a sore throat and all the other issues that we just talked about. So just get ready for it. Nausea is to be expected, but it's not considered an emergency, and it does go away over time. So let them know to stick it out if they can. If the patient stands up too quickly, they can get dizzy. It's normal, okay? We should educate the patient to dangle for a couple of minutes before they stand so the heart can catch up with the perfusion requirements, right? So if dizziness occurs, Don't give additional prescribed antihypertensive medications. Notify the provider. I know this sounds stupid, but I can't tell you how many patients I have that come in, and the reason they come in is because they're orthostatic. And I know the second I see them, the first thing I go, did you just have medication changed? Yeah, I just saw my doctor like a week ago. Did you just get it filled? Yeah, like 2 days ago. How many pills have you taken? 3? Okay, cool. So we're not going to give you more of that because we know that's the problem automatically. So if you see them with these problems, and they're physically dizzy, and they're on the borderline of their pressure, do not, I repeat, do not give them the medication. It's that simple. Expect to order to bolus them with normal saline, because that's what we always do to increase the pressure again, right? So drinking water, oh my God. So let me tell you about nephrology. I love nephrology so much. They are the coolest people in the world. Like, I did my nephrology rotation. I had Dr. Wu, one of the most amazing guys ever, worked for Avita Health Systems, still does as far as I know. Super intelligent guy. Let me tell you the one thing that always cracked me up. Whenever we had someone who had orthostasis and they had to consult him for a concomitant problem with having, I don't know, too high of a creatinine, and Dr. Wu would have to jump in to help out, he'd always go, drink more water. But you can't drink more water. That'll help our kidneys, sure, but it's not going to help our blood pressure, because the water that you drink, it goes through the kidneys, but it doesn't go into your veins like it needs to, into your arterioles. That's where we even need to do intravenous solution of normal saline. Like, okay, you guys get the point. So make sure that you understand you're going to have to bolus with normal saline. Drinking water is going to do absolutely nothing. Make sure you educate the patient on requesting assistance before ambulating, right? Because these guys are going to be orthostatic, and orthostasis doesn't go away immediately. It takes a hot minute. So bed rest is also a stupid idea. So I see people who will put them on bed rest so that they don't fall, but in giving them bed rest, what do? We increase their orthostasis, because guess what? If their body isn't moving, it's not perfusing, which means the pressure is going to be low. Come on, guys. Nursing is what? Common sense. So please have it. Please pull it out of your bodies. You all have it. It's so beautiful. I don't have to worry about 99.9% of you, but I always worry about one that might not get that concept. I don't think I'm going to have it in these classes, but make sure that you're educating your nurses, not as nasty as I do, because it's not going to go well for you, but definitely try to find a way to explain these principles to them the best way that you can. Hey, guess what? Drinking water isn't going to do jack for the fact that I have orthostasis. I got to have normal saline, and also don't keep them in bed and put them on bed rest. It's going to make it worse, and they need to get up and they need to have assistance 100% of the time, no exceptions. Okay, next slide. All right, our next medication is verapamil, and it is a calcium channel blocker, which inhibits calcium ions, which causes smooth muscle relaxation, which results in the vasodilation that we need. So it's used for treating high blood pressure. It's also used for treating angina. It's also used for supraventricular tachycardia. It may be used for migraines and cluster headaches because, again, the vasodilation. So the smooth muscle relaxation in the intestinal tract or muscles can cause constipation and cramping. This is a problem. If someone complains of constipation and cramping and they are on verapamil, you have to let them know immediately, and by they I mean your provider, because this could cause an ileus. If you have an ileus, you could then have a perforated intestine. If you have a perforated intestine, you have sepsis. We take your entire abdomen out, put cellophane on top of it, and then I look at your intestines and they ooze green most of the day. And the reason I know that is because I've actually dealt with that. I was 3 days into nursing and had this patient who was on verapamil, who had cramps, who complained about it for nearly a month, and the doctor didn't do anything and said that they were being a baby. And then they ended up with a perforated intestine, which is much worse than an ileus, because the ileus got so big and so megacolon that it became toxic megacolon. Then it burst the intestine. Then they went into emergency surgery. Then that went necrotic, and we had to take their abdominal tissue all the way down to the intestine. And the only thing separating my hand from their intestine, or the sheet from their intestine, was a thin layer of cellophane that sat on top of it. I cannot Repeat, cannot make these things up. 3 days as a nurse, and that was my day. And it was not my favorite day in the world at all. So please keep this in mind. I don't think you'll forget it at this point, because I've just shocked you with letting you know that people can live with their entire abdominal cavity exposed. Yes, that is a thing. So clients should be instructed to check their blood pressure and their heart rate before taking this medication, because it can absolutely affect a lot of things. It causes a lot of issues. Also, it is potassium sparing, so this medication does not affect the kidneys or your potassium levels. Please keep that in mind, okay? Hydrochlorothiazide. This is a thiazide diuretic or a water pill. Helps prevent the body from absorbing too much salt, which can cause the fluid retention, obviously, because wherever salt goes, fluid comes with it, and it loves it. So used alone or together with other medications to treat high blood pressure. So a lot of times they'll do what's called a hydrochlorothiazide lisinopril dose. So usually it's HCTZ of like 12.5 and then lisinopril of like 20, and that's the standard dose. And it's used to treat high blood pressure in 2 different ways, basically. Also used to treat fluid retention, edema, because again, it's a water pill, it's a diuretic. It causes congestive heart, or it fixes edema caused by congestive heart failure. There, that made more sense. Liver disease or cirrhosis, because you have the really blown up belly. Kidney disease, or to treat with a steroid or hormone medication. So medication is potassium wasting. You need to anticipate low potassium levels in the patient. If the low levels cannot be managed, then you've got to change your treatment option, period, point, paragraph. If you are watching these levels and they habitually get lower and lower and lower, you give them a potassium supplement. It's not doing anything because either they don't want to take it, they can't swallow it, they gag when they take it, whatever the deal is. Make sure that you change that medication altogether, because you have to. And there's no way around it. And I think that's all I got for this slide. Okay, now we're going to talk about my favorite antihypertensive. And yes, I don't like cardiac. And yes, I'm the lover of neuro. And for this reason alone, I'm going to talk about what I call the Big Daddy, which is labetalol. Now, labetalol is a class of medication called beta blockers. It works by relaxing blood vessels, slows the heart rate down, improves blood flow, decreases blood pressure. Okay, so we do metoprolol, and it does the same thing. So all your alols are going to do these things. Labetalol specifically decreases the sympathetic nervous system process that actively blocks the alpha and the beta adrenergic receptors, which leads to vasodilation, decrease in heart rate, which can cause severe, and I do mean severe, orthostasis. The patient must request getting out of bed. There are no exceptions. This is a Big Daddy antihypertensive. So much like most antihypertensive medications, heart palpitations, dry mouth, dehydration, headaches, most common side effects are not an emergency. Educate your patient that symptoms are reduced or stopped entirely with time. I cannot say that enough. The patient absolutely with this medication has to get up with assistance 100% of the time, no exceptions. So here's how Big Daddy works. Big Daddy works like this. I've got a patient who is no longer in permissive hypertension, who is about to have another stroke. Or worse, I have a person whose blood pressure is 170s and they have a brain bleed and they're about to get a midline shift, because the higher the pressure, the more blood that gets pulled up from that area that has the hemorrhage, right? So it just dumps a bunch of blood in there and just snaps my brainstem, basically, right? Gives me that midline shift, renders me brain dead. And I've only got maybe half an hour, maybe 45 minutes, maybe an hour at best before that happens, and it becomes so significant I can't recover it. So what I have to do is I have to give them Big Daddy. And labetalol will drop a pressure by 40 or 50 systolic in less than a minute. And I'm not even playing games with you right now. That is a real thing. Specifically when you're dealing with a hemorrhagic stroke. So you got to be super duper careful when you give it. It happens so fast that sometimes they will grab their head and go, ah, like Kevin McAllister in Home Alone. Because it is a big rush and it feels like their entire head gets squeezed and then all of a sudden just gets let go. I've never had labetalol, but labetalol was, and always will be Big Daddy to me. So again, they have to get assistance out of bed. If I give somebody labetalol and they're used to having 170, 180 pressures and I drop them down to 130, they are absolutely going to fall, see stars, and or pass out and black out. Bottom line, period, point, paragraph, labetalol is Big Daddy. There is no other. That's my baby boy. That saves my day. Hydralazine is another one that we use. It's a joke. They usually give you 20 milligrams. It's an IV push. It drops you down by 10 if you're lucky. And people always give you that as a standard and always say labetalol if it's not effective. And I always just want to go for the big guns because I know it's going to work. However, it does have a downfall, and the downfall is it can cause some significant perfusion issues to your extremities, and they can cause you to have black toes, black fingers, and black means necrosis, and that's bad. And the theory behind that is I am trying to save the core of my body, so all the little capillaries no longer matter, so I rush all the blood to the important parts, and then I constrict all the areas that don't matter, aka my fingers and my toes, and that can run into problems. It's just as bad as a pressor for someone who's on dialysis. So again, labetalol, big deal, Big Daddy. If you see an order for labetalol, don't freak out. It's okay. It's okay. If you give it to them PO, don't even stress out about it. But if you have to give it to them emergently, make sure that you're pushing it 2 to 3 minutes. Don't push it fast. Don't be that guy, because they will straight up fall out and pass out on you if you don't watch out. Okay? I'm done talking about Big Daddy. Don't forget those things that I said. All right, so captopril is another one of those antihypertensives. It's not indicated for patients with kidney disease, or if you're on dialysis, or if you got liver disease or diabetes, connective tissue disease, Marfan syndrome, like lupus, scleroderma, rheumatoid arthritis. Don't do it if you're pregnant or if you have an organ transplant. This is an ACE inhibitor. This is an angiotensin converting enzyme inhibitor. It causes orthostatic hypotension. Patients should be taught to change positions slowly. It is going to allow the vascular system to correct itself and compensate for the position change. Increasing fluid intake may counteract the effect of the drugs, so you got to watch out for that. Educate patients on chewing gum or sucking on hard candy to take care of the dry mouth issue. Blood pressure should be taken on the non-dominant arm in any newly diagnosed patient in the morning before taking the drug, and then in the evening. And that gives us a better idea of what things look like before, during, and after, if that makes any sense. ACE inhibitors cause potassium retention, so increased intake of potassium foods is a terrible, terrible, terrible idea. Absolutely terrible idea. Make sure that you're not doing it. So let's see what else. It should not be used with potassium-sparing diuretics either, because again, we're just doubling up on our potassium, and we all know that too high potassium will physically kill a person. So captopril, concomitant with any type of potassium-sparing diuretics, bad. High potassium foods, terrible. Watch out for these guys, okay? All right, propranolol or Inderal, it slows your heart rate, makes it easier for your heart to pump blood around your body, usually prescribed for high blood pressure and other heart problems, but it can also help with physical signs of anxiety like sweats and shaking. I've used it for that before. Very first dose of propranolol may cause dizziness, just like all the other ones. Educate the patient on taking it at bedtime so that they don't get super dizzy. After that, if you don't feel dizzy, you can take it in the morning, no problem, but be careful taking it in the morning. I had a patient who was a welder who was welding and took his medication, and then his medication hit him, and he burned himself with the welding rod because he passed out and fell. And that was a bad day. I actually had him in the burn unit in the ICU at Miami Valley versus having him on the neuro unit for the orthostasis, because his burns were so significant he nearly lost his hand. But guess what? He didn't. So that was cool. So just keep that in mind. Don't do it in the morning starting off. Start off doing it during the nighttime, and then if we're cool, keep on going. Side effects: feeling dizzy, tired, cold hands, feet, difficulty sleeping, nightmares. These are side effects. They're usually mild. They're short-lived. Tell your patient these things. Now, non-selective beta blockers, beta 1, beta 2, adrenergic receptors, can cause bronchospasm, especially in patients with a history of asthma. Do not, I repeat, do not. I love Nikola Tesla. Let's do it 3 times. Do not give this to a patient with asthma. That is absolutely going to be on your big 3 because you will absolutely kill a person very fast if you do this. Now, I always have a hack. If you hear systemic bronchospasm or wheezing, you know that you have done something wrong, right? If you have an allele that is a beta 1, beta 2 adrenergic receptor, such as propranolol or Inderal, make sure that if you accidentally give it, you must assess for those wheezes throughout the lung fields. Because if you've got that, you got bronchospasm, which means you're going to lose that airway. So you need to tell somebody quick. It is not even about telling on yourself and being afraid of losing your job. It is about making sure that if you need to intubate that patient in the next 5 minutes, you can do it. Okay? It is that serious. So beta blockers will have no effect on the patient's peptic ulcer disease or alcohol use, despite popular belief. Again, this is one of those myths I never quite understood. Make sure that you educate your patient on alcohol moderation, a beer or a glass of wine with dinner, and then you're cool, right? Because anything more than that might cause problems. But again, moderate alcohol use, whatever. Peptic ulcer disease, the two aren't even mutually exclusive. I don't even know why that became a deal. I guess because it's so close to, traditional issues with cardiac pain and it might mask something. I don't know why it was ever a deal, but it's not a thing, never been a thing. And beta blocker therapy is recommended after a myocardial infarct to prevent a secondary infarct by way of the acute vasodilation properties from the medication. All right, if you're watching these in order, then this is probably the 4th one you've watched, which is a lot. And if this is your first one that you've watched, welcome to the show, right? This is just today. So I wanted to give you a moment of inspiration. I wanted to tell you how proud of you I am. I think that now is always a good time to tell you how proud I am of all of your hard work. I see it, I know it, I get it. I just need for you to know that you were something incredible to me, and I hope that I show you every day that you understand how important you are. And yeah, that's all I got. So go team, go.